2021, I ended up in A&E because of medication a doctor prescribed me for a mental health illness I didn't have. Now what I understand through my public health work and lived experience is what happened to me is not an isolated story. It is a pattern, and it has everything to do with something that nobody is talking about. So stay with me. By the end of this video, I'm going to have shared with you why working mothers in their late 30s to early 40s are falling through a gap in our healthcare system. I'm going to share my true story that really highlights the cruel irony about women getting an evidence-based diagnosis. And I share my public health expertise on getting the very best out of your next doctor's appointment. Before I start, I want to stress how important this topic is, and I'd kindly ask that you give the video a like and even hype it so that more women are able to see it. My name is Zoe. I have a master's in public health and over a decade working in public health across consultancy and local government. And I'm also a coach. So this means that I spend a lot of my time sitting at that intersection of seeing what the data is telling us and also hearing what women are actually experiencing day to day in their lives. And I can tell you that there really is a gap. And that gap is the reason I started this channel. First, I want to validate how you are feeling because the exhaustion is real. The brain fog is real. The mood swings, the overwhelm, the feeling that you used to be sharper than this, that is real. You are not imagining it. And you're not weak and you're not failing. But this is what I really want to stress. The system that is supposed to help you work out what is going on in your body and your brain is the same one that has that massive gap that I was talking about. In April 2026, the government published a renewed women's health strategy for England. This one has 117 new actions. And one of the commitments is around routine NHS health checks. So health checks are conducted with people through specific times in their lives when we know that they are statistically more likely to be experiencing certain things. And for the first time in 2026, there is now a commitment to embed specific questions about the menopause. I work in public health, so I know why policy moves slowly. But let's really think about this. So that formal acknowledgement that women's hormonal health is a mainstream medical issue, a public health issue, only just happened this year. So what was happening to the women in all the decades before this acknowledgement arrived? Because something was happening and it has a name. So to illustrate this better, let me share this Reddit post. OP says, "Ever since I turned 35, my periods have been wild. Sometimes I get them every 2 weeks. Sometimes I go 2 months without one. They can be extremely heavy, last forever, and I have awful cramps. I've been to my doctor several times and she keeps telling me I'm too young for the perimenopause and that the irregular periods I'm experiencing are a normal thing after kids. My youngest is 4. She did basic blood work, but hasn't examined me or ordered an ultrasound. I'm exhausted, my brain fog is awful, and I feel like no one is taking it seriously." That story felt so familiar, and especially too young for perimenopause. That phrase is doing a lot of damage. So here's what the evidence actually says. Perimenopause, so that transition period before you have your actual menopause, which is 1 year after your last period, that can begin years earlier than most people are being told. And yet women presenting with exactly these symptoms are routinely sent away. Nearly half of women in their 40s who went to their GP with mood symptoms were given antidepressants. Most were never even asked about their cycle. And that makes sense because fewer than 1 in 5 medical students receive any formal menopause education. The NICE guidance says that for women over 45, diagnosis should be clinical based on symptoms and history, not a single blood test. And we know that a single blood test is not going to do anything because it's merely a snapshot of your hormonal profile. It doesn't tell you anything. But notice what that means for this 35-year-old presenting with exactly these symptoms from the Reddit post. She doesn't even fall within the threshold where this guidance kicks in. The system has been designed around an assumption of when perimenopause starts, but actually the evidence is no longer supporting that. And the women who fall outside that assumption, younger, postpartum, hormonally complex women, they fall outside of that guidance. And then it gets more complicated because perimenopause doesn't arrive alone for most women. It arrives at the same time as something else. So I want to read you another Reddit post because I feel, again, that it's a good example of what I want to talk about. Okay, so this OP writes, "I feel completely and totally overwhelmed by my life right now. I work full-time, I have 2 young kids, a husband, a house, and I feel like I am constantly behind. There's always laundry, cleaning, paperwork, appointments, things to buy, meals to plan, messages to answer, and work tasks to get done. Even when I have free time, I feel paralyzed and can't work out what to do first. I'm angry and irritated all the time. I snap at my husband and children and then feel horrible and guilty. One can really sympathize with this post. This is a working mum. She got 48 replies to her post, and guess what? Not one of them asked about her menstrual cycle. Not one of them asked her about her hormones, and not one of them asked how old she even was. So tell me, what she was describing, is that mental load? Is it the perimenopause? Is it burnout? Between 62 and 67% of women report cognitive symptoms during perimenopause. Forgetfulness, losing their train of thought, difficulty multitasking. Anyway, does it sound familiar? So here's the other side of that. Research from the University of Bath and the University of Melbourne, published last year, found that women carry 67% more tasks on their mental to-do list than fathers on average. And unlike physical housework, which at least, you can maybe stop when you leave the room, the cognitive household labor runs continuously during your commute, during your work meetings, during the 10 minutes that you try to sit down and switch off. So both of those things, the hormonal transition and the cognitive load, produce the same presenting picture: brain fog, fatigue, emotional dysregulation, difficulty concentrating. And so when you take that to a GP who hasn't been trained to ask about hormones, and they just see a stressed working mother in her late 30s or early 40s, the answer you are most likely going to get is stress. So maybe try mindfulness, or have you considered antidepressants? I know, because that is almost exactly what happened to me. It's June 2021. I'm 35 years old, nearly 36. So at that time, my first son was like a year and 8 months old. I had postnatal depression, and actually I still was dealing with that. We had COVID at that time, and that was really pushing my relationship to its limits. And my mom, who was a nurse, was dying. And my period since the birth had been extreme. I was experiencing hormonal shifts that I hadn't ever felt before. And the thing is, I actually never had a baseline to compare them to. So I've been put on the pill at 15 because I was diagnosed with PCOS. And so I just kept on the pill through my 20s. Actually, despite having to retest and being told that I didn't have PCOS, I just, again, continued into my 30s until I was trying to get pregnant. So my actual hormone cycle, what my body was doing just on a day-to-day basis, I had never actually really seen that before. I was also on sertraline, which is something that I was taking for quite a few years prior due to anxiety. And then after the birth of my first son, that dose had been increased to the maximum. So at that point, I asked to see a psychiatrist. The assessment was fast, it was over the phone, and the questions I can see now were really quite leading. She very quickly landed on a diagnosis of bipolar disorder. So in the moment, I actually thought, I don't think that is right, but I was in such a state of up and down, and just not being able to concentrate, and mood swings, that I really just wanted any answer, and I just wanted her to be right. My mum said she did not think it was the right diagnosis. My dad, a doctor, also said he did not think it was the right diagnosis. But I was desperate for an answer. And so I started taking the medication. Not long after, I developed full body rash, full-on flu symptoms. I felt absolutely horrific. And I actually took a photo of myself in the A&E waiting room, which you can see in the thumbnail, where I was waiting for 6 hours, only for them to tell me to just take some paracetamol and go home. So it was my mum who was like, it's the bipolar medication and you need to stop. And as soon as I did, the rash cleared, and so did my other symptoms. 2 months later, my mum died. My sisters and I were there, and it was traumatic. And the reason that I mention this is because what followed was actually a strange physical calm. The weight of not knowing, the anticipating, the waiting, it had its own kind of chronic stress. So when it ended, something in my body settled. So there was obviously grief. The grief was enormous, but that physiological tension I had been carrying, that released. So what I needed in June 2021 was not a bipolar diagnosis arrived at in one fast appointment. What I needed was someone who could see the whole picture. Postnatal hormonal upheaval, a masked hormonal history, chronic acute stress, grief, and possibly the signs of perimenopause. But nobody asked me those questions, and nobody thought to go there because I was 35. Okay, but here is the irony. Women in this hormonal window actually are at elevated risk of mental ill health. A Royal College of Psychiatrists survey published this year found that 74% of UK women are unaware that perimenopause can trigger a new mental illness. A Cardiff University study of 128,000 women found that perimenopausal women are more than twice as likely to develop bipolar disorder and 30% more likely to develop clinical depression during that transitional time. So then, wasn't the clinician that diagnosed me on the right vein? Well, if your clinician isn't asking about your cycle, your hormonal history, your age, what's happening in your body, then they're not distinguishing between a primary psychiatric condition and a hormonal transition that is mimicking one. They're reaching for a label and they're not actually taking into consideration the full context. And the consequences of getting that wrong are not always small. And as I said before, my assessment took one appointment. No cycle history, no hormonal baseline, no acknowledgement that I was 35 postpartum and on a maximum dose of antidepressants with hormonal history masked by 15 years on the pill. The training gap doesn't just mean that women get missed. It means women get the wrong answer at exactly the moment they're most vulnerable to one. So what do you actually do with this? Well, the answer is not to plan better. You're already doing too much. The research confirms that. So this is not an individual failing, but here is what's true. In the UK, at least, it's a lottery on how much your GP knows about women's health. Most women walk into a GP appointment and they describe how they feel. I'm exhausted. I'm not coping. I can't concentrate. And when you describe how you feel to a system that isn't trained to ask the right follow-up questions, you get a response shaped by whatever the clinician assumes about a woman like you. Stress working mum, maybe low mood. Here's a referral for talking therapy. You need to focus on your own agency. And that means building enough symptom literacy to walk into that appointment and be impossible to dismiss. Here's what that looks like in practice. Arrive with a pattern instead of a feeling. There is a tool that clinicians know and respect, and it's called the Daily Record of Severity of Problems, the DRSP. So it was designed as the medical gold standard for tracking PMDD, but it's just as relevant if you're trying to understand PMS, early perimenopause, or any cyclical pattern in your mood, energy, or physical symptoms. It's what my gynecologist used with me, and it was very easy to use. And here's how it works. Every evening at the same time, you rate yourself against roughly 21 symptoms across two categories, emotional and physical, and you'll have a scale of 1 to 6. 1 means no symptoms at all, and 6 means you're not functioning. So the emotional symptoms include things like low mood, anxiety, mood swings, irritability, and the physical ones include like brain fog, fatigue, appetite changes, sleep disruption, bloating. And so you mark which days you're bleeding within your cycle, and then you carry on checking your symptoms across the entire month. And you need to do this for 2 to 3 cycles. So then a clinician can look at that map and see immediately whether your symptoms are cyclical, whether they spike in the same phase every month and resolve once your period starts. So that pattern is diagnostic information. That is what the NICE guidelines say that your diagnosis should be based on. And it makes your 10-minute appointment effective and focused. You're not going in to complain, you're going in with evidence. The DRSP is free, you can find it online, but I will also link it below. So what have we established? The system has a gap in training, in research, in the basic infrastructure of women's healthcare. That gap doesn't just fail women who are very clearly presenting with perimenopausal symptoms. The fact is that women are complicated, and when a clinician is presented with burnout, stress, and anxiety, they will medicate accordingly. And as my story shows, sometimes it can be very layered in a way that no 10-minute appointment was ever going to untangle. The common thread isn't the specific mistake, it's that the hormonal context, your age, your cycle, your history, what your body has been through isn't part of the conversation at all. And when that context is missing, the clinician is guessing. Women are the ones living with the consequences of those guesses. The answer to that is not personal organization. It is structural change, and it's coming, but slowly. What do we do in the meantime? We need to focus on symptom literacy and self-advocacy. But until you get those answers from your doctor, I suggest that you watch this video next, where I share a coaching tip that can help you clear up some mental space immediately. If you enjoyed today's video, then please consider subscribing.